Hello and welcome to the Weatherford College EMS podcast, where education meets experience and textbooks meet the street. I'm joined here today with Adam and Sam, and my name is Tyler.
Today we're going to kick off a crucial chapter of your second semester, which is all things pharmacology. It isn't just about the drug names or the dosages, it's about the critical thinking, the patient impact, and why what we give matters. We're here to break it down, keep it real, and maybe even have a little fun with it. So, whether you're riding high on adrenaline or still trying to memorize the drug onset times, buckle in. We're in the right place to show you what we've got.
All right, well, let's kick it off with the first drug then. I think we're going to be talking about adenosine.
Everybody's favorite.
I think the first time I gave adenosine, I went, oh my gosh, I'm going to pee my pants. Why is this patient's heart just like going down, right? And then you're like, come back up, come back up, come back up. Like, it is very frightening, to say the least, when you're a brand new paramedic pushing that medication for the first time. Because you hear all the things of like, well, it's going to slow the heart rate down. But what is it really honestly doing? Like, what is happening here? What do you guys got?
A total reset. And it definitely has a pucker factor when you first give it and you're like, oh my God, did I just kill my patient? Oh, okay, thank God they're back. And it's a reaction you're going to have the first time you do it, the first time, especially when you push it, when you're out there by yourself, especially.
I'd say it's probably one of those things where you can say, this is going to hurt me more than it's going to hurt you.
Yeah, most people, if they've had it before, they'll tell you they don't like the feeling of it, but they'll be asking you to give it.
Right.
You know, one of the things I found interesting was that a lot of people say it's the flatline drug because you have a tendency to think that you're seeing your patient flatline or go asystole on the monitor, but realistically, that's not even happening. It's just that everything is rebooting so quickly and so fast that that's what it appears to be look like. It's like a hard reset on your computer, hitting the Control-Alt-Delete button in a sense, you know? And once it powers back up, your hope is that they will stay within a normal or a better area of their heart rate, but nonetheless, doesn't always work right away.
One of the most interesting things for me, we call it like the flatline drug, but it seldomly ever appears as a true flatline like a systole. You could sometimes actually see the underlying atrial or even junctional rhythm appear on that monitor. You've cut off the AV junction and the ventricles will sometimes fire off a PVC or two, but otherwise you can see some P waves going off, which could be pretty interesting, seeing, oh, is that a sinus tachycardia? What's that underlying rhythm there?
And now the other thing to remember too is when after you give the adenosine, I mean, we all know that we need to push this thing fast, right? It has a half-life of like 10 seconds or less.
Oh, it's super short-lived.
Super fast. But once it starts to take effect, it's not just going to slow down. There's also going to be a whole lot of PVCs usually. And this is going to be caused a lot of times because that oxygen demand for the heart is still there and present, but it's acting so quickly that it can't catch up, so that it's making the heart angry, right? And so, you know, obviously making sure that your patient is oxygenated during this process is going to help actually the way that they feel while that heart rate is slowing down. But remember, I've also talked to you all about, you know, we operate on the speed of biology. We don't just turn off and on like electricity does. So we have to have that pause while everything has to get back together and reset.
Yeah, so you mentioned the fact that it's short-lived. So in your guys' experience, what do you think about people who have a hand IV or forearm IV versus somebody who has an AC? Because we know that it's got to be followed by that flush of medication has to be, you know, rapidly flushed through, right? So, I mean, realistically, do you think it's being metabolized in the IV line before it even hits the heart if you have it in the hand or in a forearm versus having it in a central line or even in the AC?
Yeah.
Quite possibly. And there's also, you know, there's a couple of ways to approach it once you have your IV set. Obviously, you know, there's going to be some times where it's going to be difficult, especially if this patient has become hypotensive or, you know, they just have chronic issues or just bad veins. I mean, you never know, right? So, I mean, you got to take what you can get, but the goal is going to be to have something more central and a larger bore. That said, there are a couple of different ways to then administer the adenosine, right? So you do the rapid push, and then there's a large majority of people that are going to put flushes behind it. Or there's another way, the bag squeeze method, where you have the bag already hung, and you pinch off and you push it through the port, and you just squeeze behind it with the bag so you can give a ton of fluid. And that probably would be a more appropriate way to give it if you have a peripheral like hand or some kind of IV to help push that through and get it as far downstream as you possibly can.
Yeah. So I prefer that method a lot. That's my go-to.
Yeah, it's hard to kind of balance 2 syringes and clamping off and everything of that sort when you're new, first of all, but also trying to find your bearings with everything.
Absolutely.
So, we understand that we're not giving this to unstable patients. Realistically, the goal is we have narrow complex, stable patients who are hemodynamically stable, nevertheless. And sometimes, depending on the rate of the heart rate, it can be hard to tell whether that rhythm is regular or irregular. Are we coming in from a sinus or are we coming in from the atria? And so, how many of you have said that, like, okay, I'm going to give this, but I honestly have no idea if this is AFib with RVR versus this is just SVT. And you give the medication, and then all of a sudden it slows down just enough that you can see that underlying rhythm, but you're like, yep, that's my problem. This is not SVT. This is AFib with RVR. And it's not going to do anything because it's just going to speed right back up because the problem isn't in the sinus. It's in the atria at that point, right? So
you got to have a P wave for this to work. And obviously, one of the classic things about having atrial fibrillation is that you're not going to have a P wave. But it will work temporarily so that you can see that underlying rhythm, and then give the appropriate medication after that for sure.
Yeah, so Adam and I were talking about a patient that I had one time because I love working a good protocol rhythm, right? Like, you're going down the protocol and you get to the bottom, you're like, I have done it all, right? So I had a patient, they were SVT, they were tacking far into the 200s, couldn't see anything as far as what was going on, so we're like, oh, well, we're just going to go ahead and give this patient some adenosine and see what happens. Gave it, nothing happened. We couldn't even slow it down to even see the underlying. But he was stable. I mean, the guy was stable, but nonetheless, we gave another dose, and it slowed down just enough to see that it was AFib with RVR. And while we had to call in for orders for metoprolol to give an infusion of that, we said, all right, let's go ahead and cardiovert.
Yeah.
So we cardioverted, and we got him down, but we didn't get him down enough. And at that point, I had already contacted med control, and they're like, go ahead and start your metoprolol dose. And so we started infusing that. By the time we got to the hospital, the guy was great. He was within the bounds of where we needed to be and everything. And I was like, man, that was a good call. Like, got to do it all in this sense. So I love a good cardiac patient in that sense, where you get to work it all the way through.
Oh yeah, sure. I think we all do. It's where a lot of our practice comes in. What we study the hardest on is that cardiac. So
yeah. So what do you guys normally tell your patient before you push it? Do you give them any kind of warning or?
I honestly, I tell them that it's going to be very uncomfortable. There's no way to get around that. You're going to feel like the room is falling out from beneath you.
Yeah.
And honestly, I just tell them you've never felt what you're about to feel before, but it should only last for 15 to 20 seconds.
Making sure you hit that print button is a big key too. Like before
definitely.
You push it, and then letting it kind of go through so you have the entire rhythm strip. I always tell people, make sure you have paper in your monitor before you hit that switch, but at the same time, you're going to walk in like you have a book of paper afterwards.
Oh, yeah.
And then you're going to be proud of it. You're going to be like, look what I did.
Yeah, especially when you cardiovert and you get that big jolt there and everybody's like, cool.
Yeah.
But with this med, like we said, it a lot of times, like Tyler was talking about, it's not completely going to flatline, but it is very cool to watch it start to work. And when you start seeing those PVCs, you start seeing the rhythm change, and then you start seeing where you kind of freaked out a little bit, and you get to relive that every time you tell the story. But yeah, and one of the big things too to remember is you got to hit print, and you got to be looking at that 2-lead view, right? That's what we're going to be really focused on there. We're not going to be doing 12 leads. We're not going to be doing all this other mess. It's not long enough. You're going to have a very long piece of paper that you have to ensure captures all of that stuff. And then also a lot of places in their documentation they want to see that. They want to see that attached to the chart. So it's very important to have as well.
And because it's happening so quick, sometimes you can't look at the regularity. So you have it on paper, you can actually go in and look at to see, am I regular versus irregular?
Mm-hmm. Right. And you know, I know Tyler talked to y'all recently about marching things out and how to count, look at your P waves or your R waves and see. And sometimes that's what you have to do. You absolutely have to just take a big long strip of what you got, march them out, and figure out if that's irregular or not, and go from there.
So I know it's not as happening as what we see in the field today, but we do still have patients out there who have WPW syndrome or Wolff-Parkinson's-White, for those of you who haven't learned what that is yet. What's going to happen if you accidentally give this to one of those patients?
Nothing good.
So if you ever talk to any old school medics, I heard it all throughout my time as an EMT, and especially whenever I told folks that I was going to become a paramedic. Do not give adenosine to a patient that has WPW syndrome. Well, their reasoning was, you're going to kill the patient. And that just has never been enough for me. And research and all that stuff, I couldn't quite find what I needed to really back that up. So I just went with it for a long time. While there is some truth in that statement, you really want to know why. So through a lot of research on the NIH, I did find something that really backs that up. Pathways that are not involved in the initiation and maintenance of an arrhythmia leading to atrioventricular reentry tachycardia will conduct an arrhythmia generated elsewhere in the heart. In the setting of an accessory pathway capable of rapid antegrade conduction, rapid atrial arrhythmias can be conducted to the ventricle, inducing rapid ventricular rates that may deteriorate into ventricular fibrillation and cardiac arrest. So a lot of big words here on the NIH website, but what you need to know about that is it can indeed cause a lethal dysrhythmia to the patient. So you should always be cautious whenever you're giving adenosine to your patient, no matter what the condition is. Always ask about the WPW syndrome. Most folks, if they have it, they're going to tell you right off the bat whenever you walk into their house that, hey, I've got WPW, do not give me adenosine, because maybe something like that has happened in the past to them, or maybe their doctor has just recommended that they never receive that drug. Other WPW syndromes, it can be okay. I was also reading where there's an adenosine challenge to determine if your patient does have WPW, to give that adenosine and maybe see if they have the ECG signs and symptoms of an accessory pathway.
So one of the things I remember in my career is, you know, we've all heard the things that what's here today will be gone tomorrow. And with adenosine, it's like, at one point it was give 6, 6, 12, or 6 milligrams, 6 milligrams, 12 milligrams, right? Mm-hmm. Or then it became give 12 milligrams, give 12 milligrams. Then it was 6 milligrams, then 12 milligrams, or 6 milligrams, then 24 milligrams. And it's changed so much over the years, not only from the American Heart Association, but from protocols of doctors as well. And so it's really, you know, there is no standardization of dose is what it feels like, because everybody is doing something different. And I think really it just comes down to, is, you know, are they just test trialing to figure out what works? Or, you know, is there a magic threshold here? Because we know that we're seeing everything being different across the board. There is no regularity with this medication.
Yeah, a lot of this stuff obviously is anecdotal, right? Mm-hmm. We go into it and we all say, well, you know, in your experience, this is what happened to you and this is why this. And then you might come to me and tell me something and I say, well, that's cool, but let me tell you something about what I've done or what I've seen or what I've experienced. And then Tyler may have a whole nother idea or story based on his experience as well. And really, honestly, this is welcome to the gray, right? This is exactly what we talk about when we talk about practice of medicine. Everywhere I've ever gone is either 6-12-12 or 6-12-18. And that's just something that was unique based on what my medical director felt like at the time. And when medical directors change, those things will change. We have the AHA tries to standardize things, but again, the doc will come in and say, this is what I want and this is why. And again, it's mostly anecdotal until we subject a large majority of the population that this happens to a very standard study. It's just not going to come out anytime soon, even with a very standard dose. But that said, in my career, they've also changed CPR like 4 or 5 times. It's still CPR, right? But the AHA has changed that even. And so the one thing that we know for sure is that things are going to change, and that what we're learning about today, it might be something that we change it later. We might add on to it, or we might say, oops, let's stop doing that again.
Yeah,
absolutely.
And I think you got to remember that adenosine is also going to come packaged a lot differently. It'll come in a vial. It'll come in a push dose where we're popping the canisters. I mean, your vial dosages are even going to change over time as well. So you have to be really prudent in looking at those medications and writing it correctly as well. And then making sure you're going within your protocol. Because if you're, like most EMS professions, you're holding maybe 2 jobs at 2 different agencies. They may be different from one agency to the next. So you got to know what you're doing. What happens for you guys when you've given the max and they haven't converted? Do you go straight to cardioversion next, or what do you do?
So glad you bring that up, because it's not, obviously, like I said, not every time is every intervention going to work, and adenosine's no different. Even though we look at it, and a lot of times they'll say give it 2 or 3 different times, even at the same or different dosages, right? Hoping for something different. But you're right. At some point, we have to look at the problem, and we have to be able to read our patient. Is our patient stable enough to continue? Do we feel like they're trending down? Have they become unstable since? Obviously, if they've become unstable, we need to go ahead and reach into our bag at any time and cardiovert this patient. However, you always everybody has a cell phone. And every place you're going to work is going to have some way to contact a physician. We're not out there on little islands, despite what you think. Physically we are, but we can always call either a representative of your medical director, the emergency room that you're going to be transporting to, whatever they tell you that this is how we approach it wherever you work. That's always going to be the next option. And that doctor may say, hey, let's double the dose again and try that and call me back and let's see what happens. Or they may just tell you, well, if they're stable enough to get through that and they continue to be stable, just bring them to me and I will make that decision. And it also depends on like how long are you going to transport the patient? Do they have a history of this? What happened last time? And you have to have, this is why our assessments are so they're so important to get and understand and have a conversation with your patient while you're trying to achieve all of this.
Yeah, I think, it's the whole read the patient on the monitor kind of situation.
Right.
But then again, remember, before we're pushing adenosine, and even before we're setting up for cardioversion, we should always be trying to vagal them, right? So let's just say you do get them to vagal down and they drop their heart rate. Are you going to still give adenosine? And in my personal experience, no, you stop. You've got stability right there. So never rule out a good vagal maneuver is what I always tell people. Like blowing into the syringe or bearing down is always that first step of the checklist for me.
I've had this happen enough times to where I think that it might not be a coincidence, where I've pulled out an 18 gauge and I said, I have to stick you with this big needle so I could give you some medicine. And I've had a patient or two actually vagal down from that alone. Which saved me a lot of headache giving adenosine. So, maybe try that out next time too.
Why don't we move on to another rhythm that we see out there for our arrhythmics? While we're talking about antiarrhythmics today, on the other end of the spectrum, we're talking about narrow complex. What about our wide complex, such as our VTAC with pulses? And we're talking, we've got a couple of different medications from Amiodarone to Lidocaine to Procainamide. There's a couple of different ways we could talk about the usage of fixing that problem. And so, one of the fun things I found was like they were saying Amiodarone is becoming like the duct tape of ACLS, but then you find so many different things out there that are like, yes, it's awesome, but it's also not the greatest. But then Lidocaine is awesome, but it's not used as much as it should be. And so, in some areas, amiodarone, especially in the hospital setting, it's not really their first line of medication they're going to in these patients. And I like to think it's because the toxicity in it. It takes so long to get out of their system that it's kind of damaging. And one of the biggest things, not even from like a tachydysrhythmia with pulses, but even in our cardiac arrest patients, they were saying, like in pre-hospital studies, that amiodarone was, you know, yeah, it did great things on getting him to ROSC, but when you looked at the cycle of them being discharged from the hospital, nothing was really there. Yeah. Like, they didn't see anything that wrote home to them on it. So it was like, well, you can give one or the other in that sense, right?
Yeah.
And that's where I was looking at.
You know, on the topic of these rhythm control medications, in the presence of cardiac arrest, there's not a drug out there that has shown to be beneficial to a patient post-ROSC having some kind of neurological outcome.
Yeah, you could throw the kitchen sink at them and hopefully something sticks.
And here in the field, in EMS, really, the only thing we truly care about, I feel like we care about, is getting that ROSC. Yeah. We get that ROSC, we all clap, pat ourselves on the back, and we feel like we did a really good job, but you don't know what happens on the other side of that when you drop them off at the hospital, and now they are going to be on a ventilator for who knows how long as they try and rule in, rule out what caused it, anything they could fix, and then ultimately coming to a point of there's no neurological function, and now we have to pull the plug, essentially.
Yeah.
So we don't really get to see that part of it. We know that it works, and going back to the anecdotes, we see that it worked, and we think it's really good, and that's, you know, talking about amiodarone versus lidocaine and other drugs. I feel like the one that you like the most is the one that you have on your ambulance because you've seen it work. Yeah. Right?
So realistically, I felt like I was always the amiodarone person because I never wanted to do the lidocaine clock, right? Like Absolutely. I never wanted to pull up and have to go, all right, I got to do some drug math out here, where it was easier to be like, I'm just going to give 150 milligrams over 10 minutes and call it a day kind of thing, right? Because you could either slow drip that in or you could just give little bumps along the way and call it in. But you know, one of the things I was looking at as I was trying to just dive into the whole amio versus lidocaine versus procainamide stuff was like in 2015, and I know that's 10 years ago, but 10 years ago, 36 medical directors sat around and they did a survey and they looked at stable VTAC and said, okay, if we're giving amiodarone versus lidocaine versus procainamide, what are you guys doing for your pre-hospital, you know, providers? 24 medical directors said amiodarone. Mm-hmm. Now, of that, 8 said lidocaine, 1 said amio and lidocaine, 1 said procainamide and lidocaine, and 2 of them just said nothing. Yeah. I mean, they're stable. Yeah. Take them to a hospital. Right. You know, and sometimes if we're talking about toxicity, maybe that is the better route to go in the long scheme of things. Like, we're looking at liver function and keeping a medication up to sometimes 40 days in your system versus just driving them very nice and carefully to the hospital. Mm-hmm. You know, maybe they're not wrong in that sense. But at the same time, you know, amio is kind of sensitive. If it's coming in an ampule or some kind of, you know, it has to come in a glass vial of some sort. If you just shake it just right. Right. We all know it's going to foam up. Yep. Or if it's foaming up or, you know, you aspirate it too quickly, again, the consistency is going to be off. So then are you really consistent in giving that medication the full amount that you probably should? No, absolutely not. And it's not meant to be slammed in, you know, a stable environment. You know, we're talking about cardiac arrest, and we'll be talking about that later on. Yeah, okay, we're pushing everything really fast there. Mm-hmm. But in these patients, we're looking for a slow, controlled maneuver, right? I think some of us still think, well, if they're stable, I still got to cardiovert, right? You know, a lot of people have that trigger pull of, oh, should I cardiovert versus should I not cardiovert? And it's choosing medication over not. You know, you got to pick one and you got to go with it. And you can't do both. It's not a both kind of situation. Mm-hmm. So, you know, what other things have you guys seen that amio can happen if you push it too quickly?
Well, so, you know, and I've mentioned it a few times. One of the biggest problems with amiodarone is you're going to get your patient, they're going to be in VTAC, and you're going to say, I know this is really bad. Right? Like, we all know that this is going to be very, not necessarily a good thing, because that's what we've been told over and over and over and over. And what we do is we fill our syringe. We're like, okay, I'm going to give this over 10 minutes, and it's all gone.
Yep.
Yep.
Because we're in that, we are in that fight or flight. We are in that panic mode almost. And 10 minutes seems like it's too long to give it over when you're looking at that patient in the face and you're trying to decide what we're going to do. Now, when we start thinking about how all this is supposed to work, why do you think we would give this over 10 minutes? And honestly, the answer is because it's the way that amiodarone works is it's a complex kind of thing that it's working on, and it works on more than just one thing. It's not just blocking up calcium channels, sodium channels. It's not affecting, just magnesium to, for, trying to stabilize everything. Well, it affects all of it. Okay. And we've told y'all several times with several different medications that it is okay to titrate to effect, right? We've talked about Narcan. We talk about, D10, why we went from D20 or D50 to D10, because we can regulate it way better and leave our patient, instead of leaving him at a sugar of 400 that they have to then deal with for over time, we've leave them with something that's more manageable. And that's kind of what we're shooting for when we give that amiodarone over 10 minutes. We're trying to affect that change to the point where we can stop giving that med, because we don't know what exact cation that they need to be either blocked or added to fix the problem. And so what we're doing is we're taking a shot in the dark, and we're trying to affect all of it, hoping that something works. But the problem is when we start doing that, we start affecting other things downstream. Kind of like Tyler was talking about. We all high five each other when something works, but we don't know what's happening when they go to the ICU. And I know I've talked to you all about like the fluid and when to choose those things, and a lot of those studies came after we dropped them off, and then that has then trickled down to us to trying to think about what kind of fluid or how much to give. It's the same kind of thing here, is that we need to really be very careful with it, and that's why we need to give that over that 10-minute period.
Yeah, and I think the other big thing that we have to remember is that if we're giving it fast, we run that bigger risk of causing them to become hypotensive and bradycardic, and we already know that this heart is angry. We don't need to make it even more and take perfusion away from them when they're already struggling to get that perfusion level, right? So we're going to quickly make them unstable from when they were stable.
Right.
But, beyond VTAC with a pulse, what other rhythms can you give amiodarone for?
Yeah, that's the cool thing I was looking at with amiodarone is being in the hospital setting myself, I see it given for a wide variety of different dysrhythmias. I've seen it given for almost all the dysrhythmias you can name.
Yeah.
Just because it does such a good job at controlling those dysrhythmias that have a pulse, right? But just kind of jumping back a little bit when we were talking about adenosine and WPW, I was just looking up over here on the NIH, and one of the presentations on an ECG that WPW can come up with is a wide complex QRS, just because of the way that the electricity is re-entering through that accessory pathway. So another case where giving adenosine or even amiodarone in this case could cause a severe dysrhythmia. You once thought, I have VTAC with a pulse. Well, it was actually a wide complex WPW tachycardia.
That's a really good point that you bring up, because what about like prolonged QT syndrome? It's not recommended with amiodarone, but if you have something like that going on.
And these are going to be things that you can't readily see on a tachydysrhythmia very easily on the ECG printout, because everything's going to be smushed real close together. It's going to be hard to actually march things out. And what I was telling the students earlier about marching things out and looking at rhythm strips, when you start to get either too slow, why are you marching things out? You need to treat your patient. It's too slow. Why are you still counting boxes? Or if it's way too fast, why are you still counting boxes? We got to treat our patient. Well, there comes a time where we really should be paying attention and trying to look for those possibilities also.
Do you feel like, above all things, you know, everybody's got their go-to, but do you feel like Lidocaine is going to make a comeback? Do we think it's going to start becoming something that comes out of the shadows and becomes number one, like a lot of people are predicting?
I will say I've done a lot of research, a lot of thinking on this very topic, and everything that I'm finding, I know the NIH and Tyler get along very well, but I also looked at that. But I also looked at several Mayo Clinic, Cleveland Clinic. I've got several articles just right here about it. And ultimately, everything that I've been able to read that focused on it, they go back and again, they tried to get rid of the anecdotal status of, I've always experienced this versus he's always experienced that. Mm-hmm. And even through these trials where they're giving similar types of patients these drugs, they're actually finding that lidocaine has an advantage over amiodarone. Generally, if I remember right, it was 34% on one positive outcome out of the hospital versus a 38%. And another one was 32 versus 36. And then still another one that I read was actually a 28% for amiodarone and almost a 40% for lidocaine in that group. All of them were studying somewhere between 9 and about 15,000 patients. And so they all felt like they had a decent cross-section and were pretty confident in what they were finding. And all of those studies that I've read are starting to talk about are talking about lidocaine coming back to become the actual preference. However, again, this is what we know now, and this might change.
Yep.
And that's kind of where we're getting at.
So we know that lidocaine is very much something that we see people talk about all the time when they're talking about like needing a numbing medication, right? We hear it all the time, like oral surgeons and things of that sort. We're talking about it from the standpoint of the heart. It's, in a sense, blocking the nerve signals, just like it would if we were using it as an anesthetic, right? And in that, it's blocking those sodium channels in the cardiac tissue, slowing the conduction and suppressing that ectopy. And that's really what we're needing in these ventricular rhythms that have a pulse. But still, my question is, a lot of the time we have to give it prior to giving an IO, right? It's this suggestion. It's
Sure.
kind of rude to just go ahead. What happens when you have a patient that's not in one of those rhythms and they are given a little touch of the lidocaine? Is this going to affect them cardiac-wise?
I haven't been able to find anything that such a low dose is going to be able to affect anything in terms of causing an arrhythmia or dysrhythmia.
I mean, I'm going to be honest with you. If I'm giving an IO, most of the time I don't have time to set up for lidocaine.
I was going to say the same thing. If you need an IO, you need an IO. And the wonderful thing about pain is it's a pressor, okay? So if you do have that patient that doesn't need lidocaine, right, and we're worried about that maybe affecting something, you're just starting to IO because they're hypotensive. We got to get fluids on board. We got to fix this. Pain is a pressor. It really is. And you might see a small change in their heart rate or blood pressure. Not enough that we're going to keep drilling IOs to bring up their blood pressure, but it's not exactly going to be harmful to the patient to receive an IO and not have lidocaine on board. So,
do you feel like lidocaine is more of a dose? I mean, I know we do the lidocaine clock method and everything of that sort, but do you feel like it's more dose dependent because there are risks, even though it is a class 1 antiarrhythmic, mm-hmm. and it is pretty hemodynamically stable? Do you feel like it can worsen cardiac function because of the negative inotropic effects? So, in that instance, what are the risks versus rewards in the possibility of giving this medication and overdosing them? I mean, obviously we know we have to watch precaution, but do you think that we're at a higher risk for causing toxicity levels compared to where we were talking about with amiodarone being in their system for a long time?
Yeah.
Well, that would definitely be an advantage for giving lidocaine over amiodarone, for sure. It's not going to last in their system near as long as amiodarone does. But it's something, again, and I know I touched on it earlier about kind of understanding the situation that you find your patient. Doing that good assessment should then lead you towards what you're going to do for that patient. And I say that to say that, if you have a better idea of what's happening, you're going to formulate a plan way better. Okay? And when you're trying to pick between the two, you have to kind of understand, has this one happened to them before? And two, what do we think is happening with them in the first place?
Yeah.
Mm-hmm.
Right? Do we have any indication that it was something that this is going to help them with anyway? And if not, then one is more of a Hail Mary and one is more of a direct approach. And obviously the Hail Mary is going to be Amiodarone. And the more direct approach that we believe is going to help them the most is going to be taking care of it. And
I mean, I can honestly say Lidocaine's dosage has not really changed over the years for me.
Right.
It has always kind of been the exact same as what it is today.
Well, we know that it's got a very narrow therapeutic index, so it's got to stay within that window, right?
And again, I've seen Amiodarones change from the whole, 150, 150, 300 to 300, 150, 150, now 300, 150. And so I can thankfully say that I can appreciate that lidocaine has kind of stayed where it's at.
Right.
Now that I've gotten better at drug math, I'm not so scared of it anymore.
Sure.
But I mean, on the essence of all things, the flip side of it is one of the underdogs that doesn't really come to the table very often is Procainamide.
Right.
You might be looking at an ACLS algorithm going, well, what is that? If you never have been experiencing with that. So, why are we not seeing it so much in the field? And I think it has to be slowly infused, and it needs a lot of ECG monitoring, especially in a pre-hospital setting.
Yep.
Whereas we favor to amio and lidocaine.
Yeah.
And, go ahead.
I was just gonna say, like you're saying, we don't hear a lot about it, and quite frankly, before doing any research on this topic, I didn't know very much at all about Procainamide, but from that research, I pulled up a lot of notes, more than any other drug here. And I think that's very interesting, all the things that I learned about it that I just had no idea about. And just going to percentages and conversion rates, I see that IV Procainamide had a 52% conversion rate of AFib to normal sinus, and about a 28% conversion rate from atrial flutter to normal sinus. And if we look at things in the grand scheme of all the other antiarrhythmic drugs, that's pretty good.
Yeah, you were talking about the WPW, and one of the things I found is that Procainamide can actually slow the accessory pathway a lot more safely in those patients, where obviously we need to stay away from the amiodarone aspect of it. But, one of the biggest things we're talking about, you need to be ECG monitoring. It is because you run that risk of torsades by having the QT prolongation happening. And so that's why we have to be very careful with it. We've got to titrate it slowly. And if we see that QRS is widening more than 50%, we've got to stop it altogether.
Yeah.
And if it gets too long, then we have bigger problems to deal with, right? So that's one of the biggest effects what we've got to be watching when we do give that. A lot of the smaller EMS agencies that are still out there may still be using some of these things because they have old school medical directors that find this information and want to bring it out, whereas some of them just don't want to have the time and essence to want to play with it anymore.
Yeah. And again, I'm going to go to the NIH again. Sorry.
It's a fantastic website, guys. Look up NIH, type in a drug name, and you'll find out anything you need to know about it.
And according to them, they were looking at the differences between amiodarone and Procainamide and stable VTAC. They even had a nifty name. They called it the Procameo study.
Yep.
Oh.
Yeah. Mm-hmm. Yeah, Procainamide, amio, right?
Twist on it.
and it concluded that patients with stable ventricular tachycardia, Procainamide should be considered over traditionally used amiodarone due to faster resolution of the arrhythmia, fewer major cardiac events later on, and is more the efficacy is higher in the subgroup of patients that have structural heart disease.
Yeah. That's a very interesting point.
Yeah.
Yeah.
So one of the things that I found interesting of a historical tidbit was that Procainamide was a challenge to identify the Brugada syndrome.
Yeah.
So yeah, who wants to talk on that?
Yeah, so if you didn't know, the Brugada syndrome puts patients at a higher risk for fatal cardiac dysrhythmias. And there's some big ECG changes that were used to identify it. I think it came around, or it was discovered in, I think, 1992. And the doctor's name was something Brugada, right?
Dr. Brugada.
Yeah, Dr. Brugada. So he named a deadly syndrome after his name, which is cool. But yeah, so they would give this drug as a Procainamide challenge to better take a good look at that ECG strip and see, do they have the ECG changes that could identify the Brugada syndrome. And they wouldn't just give it to everybody all willy-nilly. It would be, of course, if anybody in your family had cardiac history and things like that, that really relates to that. It's fallen out of favor a little bit. There's other ways to discover this nowadays, but it did, I imagine, help a great deal of people, which is pretty interesting.
Yeah, and as we were talking about Procainamide, we started talking about like QT prolongation and the possibility of working into torsades, which then brings us into utilizing Mag-Sulfate for torsades, right? We all get excited when we see it on the monitor because you see the bow tie, right? It's like,
Yeah. Sure,
I
yeah.
know that that's torsades. But, you know, magnesium, we normally hear about it more for preeclampsia or, you know, eclampsia, not preeclampsia, but eclampsia. And then as well as a patient who's got severe asthma, but it still is a favor for torsades. And so with that, you know, it works because it is a neuro and smooth muscle modulator, but it's an antiarrhythmic. In itself, it's still an antiarrhythmic.
It is just a miracle drug. It takes care of so many different things. We give it for so much stuff. It's really interesting.
It really stabilizes that cardiac membrane when it's just freaking out in a sense, right? It's the same thing as with our patients who are having eclampsia. It's stabilizing the central nervous system. And the same thing could be said with bronchial smooth muscles in an asthmatic. So it's really just the chill factor of drugs, of all things. I wish that it was used more in other situations, but it is easy to cause a mag toxicity in these patients.
Sure.
Mainly because it's one of our primary electrolytes, right?
Yep.
Absolutely. Yeah, one of the things that you have to be very aware of, like Sam was talking about, is the toxicity. And there's lots of different symptoms associated with that. Obviously, we've got the big bad ones, altered mental status, things like that. But really, the easiest way to start to discover mag toxicity, and this is something that I do in my practice and that I've taught over the years, is that they're going to first start losing that deep tendon reflex. Okay, and if you just have in the back of your head, if I'm going to give mag, and I don't care why, if it's torsades, seizures, bronchospasm, whatever you're treating, if they start adding things that you can treat with mag, which wouldn't surprise me in the next few years that list gets longer of things to give mag for. But if we're going to start doing that, the thing that we have to do is, and that's the easiest, is find that reflex in the knee, right? And honestly, it's very simple to do. You find it, you put a little mark on it, and every about 3 to 5 minutes, just go back and knock on that thing and make sure you still get a response. If you get a response, you're still good to go. Keep rolling with the treatment. Mag is a fantastic drug. It treats a lot of things, and it's very, very effective. Like Sam was talking about, being able to stabilize those cells. And part of the issue too is when we start talking about, you know, things that block and everything else, we also then need to sometimes stabilize. And one of the things that is happening in torsades is that it is a polymorphic VTAC, right? And as we start talking about, well, what does that mean? Well, it means that signal is coming from more than one place. Okay, and that's why the mag works with that torsades, is that it's going to stabilize that to hopefully focus that intensity, that that excitability to where it's supposed to be, so that then the firing of the ventricle is going to then slow down. And then when that happens, it'll regulate itself out back to where it's supposed to be.
You know, we talk about patients having some electrolyte disbalances. Did you think about the fact that if we have a malnourished patient, or maybe even a patient that has some alcoholism or chronic illnesses, that MAG actually might be a really good benefit to them, because they have low magnesium levels. So it might correct that underlying cause in all essence of things. But also, there are things where we give MAG and it could cause vasodilation in patients if it's given too rapidly. And so, in a sense, we could be going the opposite route and causing them to go into cardiac arrest.
Yeah.
So we have to, you know, play a little nice and get a good thorough history on these patients and pay attention to what we're doing and giving and making sure it's the right time. I kind of want to switch gears and go over one of Adam's favorite topics, calcium channel blockers.
Love them.
You know, you've got Diltiazem, and then you got the good old Verapamil, or what we used to always call Verapakill. I don't know anybody who can't say Verapamil and not say that right afterwards.
Yeah.
What do you want to start with, Adam? Diltiazem, or you want to go Verapakill?
Well, I kind of want to talk about both of them at the same time, because I think it's important to understand. I mean, we've mentioned a couple of things, like with Procainamide being a sodium channel blocker. We're going to get into this. This is a calcium channel blocker. You need to have this understanding of what is this? What does this mean exactly? What is this function? And I was kind of getting into that a little bit with my comment on MAG, but what you have to understand is whenever you start activating the action potential of that cell, okay, you're going to have your potassium's going to leave, your sodium's going to rush in, you're going to have your squeeze, right, and it's all going to go back together. Well, what allows that for that potassium to leave the cell are those channels that open up all around it. And there's sodium channels, calcium channels. There's even a little bit of magnesium channels. Not very many, but there are some. And in fact, those are the ones that kind of consistently open up to allow for those little minute changes that hold the consistency of that cell as it sits at rest. So if the needs change, then you actually have a little mag channels that'll open and close for that aspect. But we're talking calcium channels for this one, and the calcium channels are the major guys. Now, if you start thinking about it in terms of when the cell reaches its action potential and what it does and what it looks like on the EKG, if you start plugging up those channels, obviously it's going to take longer for this reaction to happen, which is going to mean that it's going to take the reaction time is going to be longer, and it's going to elongate that QRS especially. And as we start thinking about, well, why would we want that to happen exactly, right? Obviously, we have the simple answer where we say it's too fast, right? Things are just too fast. This will slow it down. Done and dusted, right? Well, it's a little bit more in depth than that, right? So as we start blocking up those calcium channels and we start elongating those things out, remember that because we have those two refractory periods. Now, we don't really have to worry about the R on T on this one, right? Because we're talking about elongating the absolute refractory period, okay? Your T wave in the repolarization phase is not really going to be affected by this. So we're not really going to have, an increased risk of creating these issues by giving the calcium channel blockers, or even sodium channel blockers for that matter, as long as we're not extending them out too long. Yeah. Then we start having bigger and better problems, right?
Yeah, so one of the interesting things that I was taught was that calcium channel blockers are like the chill pill for your heart, right? Yeah. So in this instance, we see like Diltiazem, or, a lot of people like just call it Cardizem, but nonetheless, we see it a lot with our AFib RVR patients. And with that, it's just slowing that conduction through the AV node and reducing that overall workload of the heart, because we know we need oxygen for perfusion, right? And so it's just telling the heart to relax. But if we're going to jump back over to the whole AFib with RVR and maybe even a little WPW with it, it's not really a good thing to give Verapamil in those patients. It blocks the AV node, and that can push conduction through accessory pathways, worsening the arrhythmia. is one of the big things that I found in those patients. And I know we're talking a lot about WPW, but that's where a lot of arrhythmias are occurring in these patients. And so it's really good to know what we're dealing with and to make sure we don't give the wrong medication to these patients.
Yeah, definitely.
Now, in your personal opinion, would you say that calcium channel blockers have the potential for rebound tachycardia?
Absolutely. One of the issues, and I kind of talked a little bit about it earlier with like adenosine, having that myocardial oxygen demand is still there when you slow that rate down. It can also still happen with both actually sodium and calcium channel blocking agents. However, calcium channel blockers, it happens more often because there are more calcium channels that have to open up to allow this exchange to occur. And so therefore, when you start slowing that down, the demand is still there. Again, we're on a little bit of a delay, right? And so as we feel like, hey, this is working, yay, high five, the body might not see it that way. And the body might say, I don't have what I need, I'm going to ramp up. And as soon as it can, as soon as the effects of this calcium channel blocker wear off, all of a sudden, that heart rate is higher than you started off with, and you might think, well, now wait a minute, I thought I high-fived my friends. This is done, right?
Yeah.
We're through and over. I fixed the problem, and honestly, because of that rebound reaction of the body saying, okay, I didn't get what I want, now I'm going to get what I need. We all know that these compensating measures that our body likes to go into don't always solve the problem.
Yeah, and another thing is that it can drop your blood pressure rapidly with those. And we already know that they have an increase in myocardial demand, that this is not a good thing if we're dropping that blood pressure. We'll talk more about that when we get into ACS drugs, but, the whole FONA versus MONA situation, again, ties right into that. But nonetheless, if you're going to compare Diltiazem versus Verapamil, which would you rather have on your drug box?
Personally, I'm a fan of Diltiazem.
Yeah.
I have found, and again, this is anecdotal, but I have found that truly Diltiazem is a very safe drug. It's an effective drug. In speaking to other people and doing other research, the instances of hypotension are actually less with Diltiazem than Verapamil. Thank you. So in that instance, really, in my opinion, Diltiazem is the one that I would go with.
Yeah, I think it's a lot less riskier compared to Verapamil.
Yeah, Verapamil, it's just more potent in general.
Yeah.
So, you see a little bit more of the vasoactive properties with the Verapamil, a little bit more hypotension.
Yeah.
Compared to other things like Diltiazem.
Now, what happens in your situation, you give Verapamil and the pressure just tanks? What's the first thing you're going to do?
Fluid challenge.
Absolutely, right?
1000%.
But then what about the possibility of, we know we are blocking the calcium channels, right? Mm-hmm. So why not give a little bit of calcium chloride or some calcium gluconate and see if we can turn this back around? What's your thoughts on that?
Well, I'd feel more comfortable with doing that if I was suspecting maybe that we're having a toxicity issue, right? Mm-hmm. Maybe the patient's already on a calcium channel blocker at home that I didn't know about, and I gave the Verapamil. Then I would probably lean more towards giving calcium.
Yeah, that's a really good point that you bring up. I mean, the other aspect is, what if that's not the problem? Mm-hmm. Maybe we go to repressor instead and see about bringing them back up that way, right? And try to fix it from that standpoint. That's a good one. I don't know how to say this last one. Have you heard of non?
Yeah, I'll say it. So, in regards to calcium channel blockers, a word that we might not have ever heard before is non-dihydropyridine. And
what?
That's
say that again.
A non-dihydropyridine.
3 times fast.
Non-dihydropyridine.
Right over my head.
Yeah, so that is a classification for calcium channel blockers. We know that there's a large variety of calcium channel blockers, but did you know that they're grouped up into 2 classes, the dihydropyridines and the non-dihydropyridines? Your dihydropyridines are going to be more of the vasoactive drugs, things that are going to be causing more peripheral vasodilation to help with blood pressure issues. That's where you're going to see amlodipine and drugs like that, drugs that end with "ine," right? And then on the other end of the spectrum, we have our rate control medications like diltiazem and verapamil, which are going to be the non-dihydropyridines. And that's what we're going to be giving in the pre-hospital setting most often. It's good to know that there's two different classes for these drugs.
So have you guys heard that diltiazem can cause heart blocks?
Sure, I've heard that.
So, I think it's safe to say that if you have a patient with an existing condition or even sick sinus syndrome, it's why we avoid it in our second and third degree heart blocks, especially if they, unless they have a pacemaker of some sort. But why do you think that is, that it's causing heart blocks?
So through the research on the wonderful NIH, I have here, and we're going to use that fun word again, that non-dihydropyridines exert inhibitory effects on the SA and AV nodes, thereby slowing the cardiac conduction and contractility. That allows them to effectively slow down that and potentially cause a heart block.
Yeah. So do you think that you're seeing more medical directors now go into putting, cardizem on the box versus taking the verapamil out? I mean, I feel like we're now in a period where we're seeing more and more of it coming out in the field setting. What are you guys' thoughts on that?
Well, this might not be a direct answer to that question, but from what I've seen in my history with being on the ambulance is at one point in time they just took away calcium channel blockers in general. And the point I'm going to make is that we get so caught up with trying to treat what's in front of us, treat what's on the monitor, and we have a drug for that. We've got something right here. Whatever your problem is, I'll cure it. But we're not looking at what's causing it first.
Yeah.
We're not doing a thorough patient assessment, and we're going to give some diltiazem to a septic patient that is having a compensatory mechanism, and we're going to drop that down. And I think it's pretty safe for the medical director to say, let's take that out and let the patient ride to the hospital with AFib RVR rather than, the handful of patients that they tank that were just septic.
Yeah, you make a really good point. I think a lot of people also forget to diagnose stable versus unstable. When we're talking about these medications, we're talking about patients that are stable versus the ones that need some kind of energy. They need to have their world rocked for a second, right? Mm-hmm. There's a lot of great Band-Aids on here to help fix the stable patient and hopefully get a long-term outcome. But realistically, it's a thorough assessment of knowing which route you need to be going in the right time. And so, we've talked a lot about tachydysrhythmias. On the other end of the spectrum, we still have one for our bradydysrhythmias.
Right, yeah.
We still have good old Atropine is still making its force. I mean, we know it's been taken out of ACLS as far as cardiac arrest goes, but it is still technically there for stable bradycardia.
Right.
And again, that dosage has changed for me from 1 milligram to 0.5, back to 1, back to 0.5. Who knows what it's going to be in a couple of years, or if it'll even still technically be around.
Right.
What's your guys' thoughts on it?
Well, you bring up a good point. I mentioned earlier about during my career them changing CPR. Well, Atropine was one of those changes that happened in my career. I remember the first couple of years it was epiatropine. Mm-hmm. We've since kind of learned some things, and that's been taken off. But the thing about atropine, and something I want, a concept that I want to introduce is how it works or why it would work. And this is one of those drugs that's a little bit different. We have these other drugs that, we were talking about mag stabilizing things. We were talking about blocking up calcium or sodium channels, things like that. However, with atropine, we need to have a different idea. It's not a drug that we give that causes something to happen. Mm-hmm. It's a drug that blocks something to allow something else to happen. It's almost like if you go to, I don't know if they exist anymore. I know at my grandma's house, they had in the shower, they had the hot and the cold, right? And so if you turned up the hot and the cold all the way up, if you wanted hot or you wanted cold, you had to turn one down.
Yep, you had to taper around.
That's what atropine is doing.
Mm-hmm.
It's shutting one of those off so you get a greater response from the other side. And what I'm referencing is the parasympathetic response.
Yeah. I think it's important to know where atropine's really not going to work versus where it is going to work. It works at the SA and the AV node, but what ends up happening is you see patients who have a low heart rate, maybe because they have a 2nd degree or a 3rd degree block, and they're like, oh, well, they can't diagnose it in the field because they're not looking at it, right? And they're just like, oh, the heart rate's low, and yeah, maybe they're missing a drop to beat here and there, or something of that sort. But realistically, the reason atropine is not going to work is because that's not where the problem is. It's not in the SA and it's not in the AV node. It's in the ventricles, and it's lower than the AV node, and so atropine's not going to do anything for that. And so you're just kind of wasting the tidbit. But at the same time, I found out that if you have too low of a dose of atropine, you can actually stimulate the vagus nerve and make the heart rate drop even more. And so maybe that's why we've seen the changes up and down in the roller coaster aspect of this dose over time. But realistically, I know that a lot of the time when we're seeing how to treat our heart blocks, it very clearly states, like, you could give atropine, but it's probably not going to have any kind of effect on this patient. So, right. Pacing is better. That's the biggest thing that I take away from it. I know we're still technically seeing it out there as an antidote in organophosphate poisonings. And that, again, comes back to what you were saying, Adam, on the parasympathetic nervous system aspect of it. What about in patients, and I know we don't see them out there very often, but what about our heart transplant patients?
Yeah, so when somebody receives a new heart, obviously, they got to get rid of the old one, right? And in doing so, they actually physically have to go through the vagus nerve. Like it is cut. The heart then is not going to be innervated by that vagus nerve anymore. And because of that, obviously, atropine is not going to then be able to stimulate it or allow for the stimulation, the increased stimulation of the vagus nerve to be able to bring down or bring up, the heart rate. So it's one of those things that a thorough assessment and understanding what has happened to your patient, a history is going to be very important, because you may look at something and say, oh, okay, I know exactly what this is, and then why is this not working?
Yeah, and you make a good point about a patient history. Some patients just live in a state of bradycardia, right?
Right.
Like our track star runners or our very healthy patients. It just happens.
My mom.
And so, we have to remember that we're not just going to walk up to somebody with a heart rate of 40 and just start throwing atropine at them or pacing them because we feel like that's what's needed. We need to do a really good assessment on these patients and make sure that that's just not what their norm is, right? That's why we always try to say, like, normal is not normal for everybody.
You also got to look at the possibility that your patient might be on a beta blocker.
Exactly.
So they have the hot water turned off.
Yep.
And your parasympathetic is not going to help in that situation because the sympathetic nervous system has also been cut off.
Yep.
So
that's a good point. All right, well, that's a wrap on this episode of Weatherford College's EMS podcast. A big thanks for tuning in as we kicked off our first pharmacology podcast. A topic that can feel intimidating, but we promise it's going to get clearer with every call and every repetition. From Tyler to Adam to myself, with the field-tested knowledge that we have, we're here to guide you through it every step of the way. So stay curious, ask questions, and never stop connecting the dots between medications, the pathophysiology, and the patient. Until next time, stay safe, stay smart, and don't forget, it's not just about knowing the drugs, it's about knowing what they do and why.
See ya.